Hi everyone, I hope everybody's doing well. So today our topic is cognitive decline associated with anesthesia and surgery in older patients. This is an article that was published in Journal of American Medical Association. It was published on September the 7th, 2021, so it's a recent article by Dr. Susanna Vakis, Dr. Danielle Cole, and Dr. Maxime Kennison. This is an article that's important from surgical and anesthesia point of view, especially for non-cardiac surgeons and non-cardiac surgeries that are performed on patients who are older than 65 or above. So when we're talking about age causes a number of changes in the brain that contribute to a decrease in cognitive reserve. And susceptibility to stresses like surgery and anesthesia increases the risk of neurological injury. So it is potentially the cause for post-operative cognitive disorders. Now, what are post-operative cognitive disorders? There's two terms that come under this umbrella term. These are delirium and post-operative cognitive dysfunction. Delirium is basically acute state of confusion and inattention, but post-operative cognitive dysfunction is a prolonged state of cognitive impairment that predominantly affects the higher levels of cognitive skills as well as memory in these patients. Previously, delirium and post-operative cognitive dysfunction were considered different entities. However, now they're kind of under this umbrella term because they have overlapping features. Now, what's the potential mechanism for this injury? We don't know, but the hypothesis is that neuroinflammation as a result of perioperative stress, vascular disorders, or the acceleration of neurocognitive decline in patients with previously undiagnosed neurodegenerative disorders, such as preclinical dementia, are at risk. So basically, these are the people who are older. They have some neurodegenerative disorder, but it's not diagnosed yet, or it's subclinical, as in they don't have a lot of features of dementia. So these are the people in which there might be these changes that are very visible after administration of anesthesia. Okay. So among the patients who are over 65 years or older, up to an estimated 65% experience delirium, and 10% develop long-term cognitive decline after non-cardiac surgeries. Complications associated with delirium include longer hospital stays, more days with mechanical ventilators, and functional decline. Now, there is delirium that appears in patients not right after their surgery, but a little bit later. So after they're discharged, they may develop a post-operative delirium, and this delirium is associated with increased risk of worsening of functional and psychological health, with progressive cognitive decline, dementia, and even death. Okay? Perioperatively, what we can do with these patients. Now, this is basically a complex interaction between a patient's baseline vulnerability, like how vulnerable they are, how at risk they are, and other risk factors that may be associated with these patients. Commonly, the non-modifiable risk factor that we focus on is the age. Other risk factors are compromised higher level of cognitive skills, as we said, having some level of neurodegenerative disease or disorder, and the procedure that is being done. So how invasive is the procedure? How long is the procedure? And if the procedure was done in urgency or emergency. This matters, as well as a post-operative admission into ICU. Okay? So, although there are no compelling medical or pharmacologic or intraoperative interventions that have shown to lower the risk of post-operative neurocognitive disorder development, but there are some guidelines that we can follow in patients who are potentially at risk. So, among the patients who are over 65 years or older, avoiding medications such as benzodiazepines and centrally acting cholinergics, meperidine, phenothiazine, and antipsychotics in the perioperative period decreases the risk of cognitive changes. Another guideline is by WHO, and they say the strongest recommendation is to focus on physical activity and tobacco cessation, nutrition, and management of hypertension and diabetes. So basically, managing the other risk factors, as we mentioned before. Okay. Now, there are certain studies that have been done. So what happened in these studies was they took a cohort of patients and they divided them into a control group and a study group. And then what they did was, for the people who were in the study group were undergoing training with orientation, cognitive stimulation, as well as mobilization. And this was sort of to train their brain before having the surgery. However, there were not a lot of changes that were seen, and there was not a lot of benefit that was seen in these patients, in both of these studies. The problem with these studies was technical issues, they said, because some of the patients, it was harder for them to do the cognitive rehabilitation program. Some of them had reported saying feeling overwhelmed. They were nervous about this surgery. They didn't want to do the cognitive exercises, or they were unable to do the cognitive exercises. So therefore, the results of these studies are kind of not that well established. So studies have also failed to show meaningful differences between regional and general anesthesia. So when we're talking about anesthesia risk, we're talking about both of these risks. We're talking about local anesthesia as well as general anesthesia, because no studies have been found that showed the difference between these two. Also, they didn't find any evidence for specific anesthetic agent. So all of the agents at this point are sort of considered to be risky agents, because no agent stands out in any of these studies. Okay. One of the studies that was published in 2018 showed that EEG-guided anesthetic administration was helpful in some patients. However, another study the following year that was published in 2019 showed that there was no decrease in incidences in post-operative delirium with EEG-guided anesthetic administration. However, it is hypothesized that it would be beneficial for primarily for people who are cognitively frail. So it would be advisable to have an EEG-guided anesthetic depth in these patients to administer the anesthesia according to the EEG findings of that patient during the surgical procedure. Now, what are the future concerns with this type of study and this type of finding? Anesthesia and surgery are shown to be associated with modest acceleration in the rate of cognitive decline in older patients. How this acceleration might be magnified in the patient already at steep trajectory of cognitive decline, such as pre-symptomatic Alzheimer and related dementia, is unknown. So basically what they're saying is how this is related to them is kind of unknown. However, there is some evidence that suggests that specifically for like Alzheimer's patients, that anesthetics may be associated with an increase in cerebral beta amyloid deposits, which are the cause for Alzheimer's disease. Okay, so we don't know why it's happening, but there's still a modest acceleration in the rate of cognitive decline in older patients with anesthesia and with non-cardiac surgeries that we're concerning ourselves with right now with this article. What is in the conclusion for this? So advances in surgery and anesthesia can improve function and quality of life for older patients, but not without potential risk to their brain health. Postoperative neurocognitive decline is a meaningful concern for patients and represents a significant and expanding challenge to the healthcare in US as well as worldwide. Surgeon and anesthesiologists should assess, discuss, and optimize associated potential risk factors for each patient before surgery. Now, best practice is to have a plan before the surgery that gets extended into the recovery period for these patients. So be prepared. Know what type of surgery is happening, know the age of the patient, know the risk factors in the patient, and know how to decrease those risk factors that we can decrease. The risk factors that we have no control over is something that we might be able to have some studies in the future, and we might be able to control those as well. But right now, we're focusing on the stuff that we can control. So specifically for patients who are depressed, they should be treated before the surgery. They should be counseled as well. Hypertension, sleep disorders, and diabetes should be in appropriate controlled rates. Alcohol and other substances should be controlled as well. Patients should be off any of the substances and or be treated for alcohol or substance use disorders. Medications, as I said before, benzodiazepines, anticholinergics, which are centrally acting, phenothiazines, meperidine, and antipsychotics should be avoided in these patients in perioperative period. Nutritional status should be maintained. Perioperative pain should be managed, and family and social support system should be supplied for these patients. So that is it for today. This was a longer topic. However, I feel like this was an important piece of article that is important for surgeons and anesthetics with recent increase in older patients coming in for surgeries. Alright, I hope you enjoyed today's video. Please like, comment, and subscribe. Thank you for watching. Bye.